All righty, we're ready to start back with our last presentation. And I know you all enjoyed Dr. Tallent so much earlier this morning that we're happy to have him back again. He's going to be talking about hypersomnia conditions, assessment, and treatment. So let's give a round of applause to Dr. Tallent.
It seems to me in medicine, sometimes we feel the need to rename things that don't really need to be renamed because the original name probably made better sense. So I think narcolepsy with or without is pretty self-explanatory. So, and then
But it's not good sound.
idiopathic hypersomnia. Whenever you see somebody that's sleepy during the day, by far the most common cause of that.
Time first described in 1880. Usually it presents before age 25, usually adolescence to early adulthood. That being said, though, sometimes you do see people who are in their 40s, 50s, 60s who have never actually been diagnosed, but they've always been labeled a quote unquote sleepyhead, because obviously with narcolepsy, it's not usually like you see in the movies where people just fall out on the floor asleep from wide awake. Usually it's just somebody who feels drowsy a lot, and given the right circumstances, they tend to go to sleep. So it's a bit different than the perceptions that a lot of us have. The classic tetrad for narcolepsy is, of course, the excessive daytime sleepiness, which is kind of the first and foremost symptom that you notice. Cataplexy, which can or cannot be present. Hypnagogic hallucinations, sleep paralysis, and automatic behaviors are also frequently present. The prevalence of narcolepsy is about 1 in 2,000 people in the US. There's a similar distribution, female to male. There was a European general population study that was large in terms of the number of people that it looked at, and the prevalence was roughly about 0.05%. The lowest, if you look at different individual groups, and of course this hasn't been studied in every individual group, but in some of the groups that have been looked at, the lowest appeared to be in Israeli Jewish individuals, and the highest was actually in the Japanese study. It's complex in terms of the development of narcolepsy. There appears to be some genetic susceptibility, but as with many things that are postulated to potentially be autoimmune, it likely it likely takes a multi-hit process. So in other words, you have to have the genetic predisposition and also the autoimmune trigger. And what we mean by that is it can be sometimes just a routine type infection that a lot of people get that will then trigger that autoimmune process. It's not just in narcolepsy, that's in a number of different autoimmune things that you see. So that's why you don't see a lot of first degree relatives necessarily that automatically get it. You can have familial cases, but certainly whenever you see that, that points in this direction. Some of the signs and symptoms of narcolepsy, of course, the hallmark symptom is excessive sleepiness. The more commonly, the sleepiness that you see with narcolepsy is described kind of as a sudden onset sleep attack, where, and it's not necessarily, again, that they just fall out. It's just that they say, all of a sudden, well, this just wave of sleepiness has come over me. It's not necessarily that they can't try and fight it. Versus with idiopathic hypersomnia, oftentimes that's kind of described as sort of a almost constant kind of mental fog, sort of a low alertness level, that kind of a presentation rather than actual frank sleep attacks. This is usually the biggest problem for individuals because it interferes with safety, it interferes with social interaction. You know, obviously, driving is the biggest situation, you know, for most of us drive. So therefore, that's the situation that it's most dangerous in. But obviously, certain individuals, you know, if they work with heavy equipment, farmers, you know, things like that, you have to be really careful. If you look at the sleep duration over a typical 24-hour period for individuals with type 1 narcolepsy with cataplexy, usually that's less than 9 to 10 hours a day. So, you know, and a lot of people actually get 9 to 10 hours of sleep. You know, it's more consolidated, and then they don't feel that sleepiness during the daytime. Versus idiopathic hypersomnia, those individuals can sleep 10, 11 hours or more potentially in a 24-hour period. So when someone says that, and you have to be careful just when you're asking people about excessive daytime sleepiness, sometimes it can be difficult to quantify that. So, you know, they may say, I feel sleepy all day, but what they mean is all throughout the day, they have several episodes of feeling sleepy. So that's why you have to really kind of nail down the details on when they're feeling it and for how long, and if they take naps, how long those last. But you can see sort of that long sleep phenomenon, of course, in narcolepsy. But when you do, typically you see it more in narcolepsy type 2 rather than type 1. So the individuals without cataplexy. But that can be in about roughly 1 in 5 narcolepsy patients. All right, there we go. Couldn't get it to advance for a second. Another telltale sign of narcolepsy is cataplexy, because in general, when you see or hear of it's narcolepsy until proven otherwise, you know, assuming obviously you can take the account for face value. And cataplexy is a sudden, typically bilateral, if it's unilateral or just one side rather than affecting both sides of the body, look for other things until you've absolutely ruled it out. There are some reports of unilateral cataplexy. That's very unusual. Something unilateral usually implies a separate neurological process, but it is most commonly bilateral by far. And it's this transient loss of muscle tone triggered by emotions. And you have to be careful, you know, when you're talking to people about this, you know, you really want to nail down that it's the emotion that is triggering that, okay? And they have preserved consciousness throughout. So it's not that they're going to sleep, you know, it's not that they are surprised and they fall asleep. They're alert. And it's typically more subtle than most people think. It's not like the fainting goats, you know, like you see the videos of those, you know, where you clap your hands behind their head and they fall over. Usually it's, they say, you know, when I laugh at something really hard, I notice it's like, I don't want to hold my head up. So it can be very subtle. Or some people feel like their legs kind of start to give way. So they, not necessarily that they would buckle, but they feel more comfortable sitting down, that kind of thing. Very transient, usually just lasts seconds to maybe a couple of minutes. The most common trigger for that, the typical cataplexy, is brought on by laughter. So that's the first thing to ask people about, but it can be other things. The second most in my experience is usually being surprised. Like if you come around a corner and you don't expect something to be there, then they can feel like, ooh. And a lot of people just describe it as feeling like they're kind of melting, that sort of thing. Typically not. And for this talk, we've got so many slides, we may have to save questions for the end. No, I mean, I'm happy to address them. It's just we're trying to get through so many slides, but I'll be happy to do that. And an interesting finding during cataplexy is that deep tendon reflexes are absent, but it's only during the event. They have reflexes at other times. It's just when they're cataplectic, they lose their deep tendon reflexes. So if you ever see anybody doing that, and I'm well enough to do this, obviously, you can go over and check their knee reflex, which is the easiest to elicit, and you won't get a reflex. So that's another telltale sign that it's cataplexy. But they have normal sensory input, memory of the episodes, that sort of thing. Muscles that are spared are eye movements and, of course, respiratory muscles. So it doesn't affect their breathing. Right. And again, this is just a slide showing some of the different things that can bring that on. It can be, sometimes feelings of a lot of happiness, all those kind of things, or sometimes it can just be a particularly emotional memory. Cataplexy usually comes on after the excessive daytime sleepiness presents. So what may appear to be narcolepsy with cataplexy later can turn out to be narcolepsy. Did I say that wrong? What initially appears to be narcolepsy without cataplexy can later be narcolepsy with cataplexy. Usually it's within just a few years that you'll see that if it's going to develop. There are reports, though, that it may happen for the first time as much as 10 years later after the original diagnosis. Usually the most commonly affected muscles are those of the neck or face. Some people will even report a droop, so almost like a slurring of the speech. So it can be subtle, and they may say, I don't know what it is, but if I experience a strong emotion, I slur my speech for just a second afterward. So it's very interesting, so it's in that spectrum of possible stroke mimics. And then, of course, muscles. And it gets less frequent typically as we age, interestingly, but that's also interesting too. So, a lot of conditions that cause excessive daytime sleepiness, not necessarily narcolepsy, but a lot of the others, you can notice less daytime sleepiness as we age. So that can actually improve. The prevalence in narcolepsy with regard to cataplexy is anywhere from 60 to 90%. And interestingly, not only is it narcolepsy type 1 that you can see it in, you can also see it in a few other neurological conditions, including Niemann-Pick disease, type C, pontomedullary or brainstem lesions, and Norrie disease. Sleep paralysis, another thing that is certainly not exclusive to narcolepsy, but you see a lot of it in narcolepsy patients. And that's that transient inability to move at the sleep-wake transition, again, with intact consciousness, okay? And that can be either when you're falling asleep or waking up out of sleep. The lifetime prevalence for this, though, can be 6%. And I'm sure we've all known people who have had sleep paralysis. In fact, a lot of people, notice that and just never mention anything about it. So this prevalence percentage may be much higher in reality. But that's where, people, when they're first falling asleep or waking up out of sleep, again, more common to be waking up out of sleep for the general population. When you notice it when you're waking up out of sleep, during the night, then that points much more toward a likelihood of possible narcolepsy. Of course, if the other symptoms are there. But it's in up to 2/3 of patients with cataplexy, but you also see it in 1 out of 10 without cataplexy as well. It can resolve spontaneously after a couple of minutes, or interestingly, tactile stimulation can bring people out of it. So if you ever see someone and it appears they're having sleep paralysis, oftentimes they'll kind of groan or moan. So all you have to do is touch them, and then it releases them from sleep paralysis. You get that sensory input, and then that releases the muscle inhibition at the level of the brainstem. And again, it's seconds to minutes. One thing I put down at the bottom here is there's a colloquial expression in the South. And if you hear somebody complaining of the witch riding me, that's sleep paralysis, because that's just in decades past, that's how a lot of people described it. It was a nightmare, because oftentimes they thought, it was a nightmare, but it was really just a hypnagogic hallucination associated with the sleep paralysis, because they can't move. And a lot of people will notice those hallucinations, and for whatever reason, typically they're threatening. Okay, a lot of people will see kind of a dark shadow figure standing in the room, and these are not stationary like the complex nocturnal visual hallucinations that we talked about earlier. These can move. You can actually even see the whatever the hallucination is move towards you. There's a threatening, ominous feeling oftentimes with it. Some people feel as though they're even being held down, or that they can feel the bed depressed, like something just sat down next to them, things like that. We don't exactly know why. It tends to be ominous or threatening, but probably it's because there's been some involvement with some of the nuclei mediating a fear stimulus, like the amygdala, for example. But you can see these hallucinations in 50 to 70% of individuals with cataplexy, but also commonly 30 to 40% of individuals without. And there is a higher incidence actually in individuals with idiopathic hypersomnia too. So in up to 1 in 5 of people who have IH. There was a large community sample years ago, and 25% reported hypnagogic hallucinations and 7% hypnopompic. So as you can see, it's definitely a common scenario. And it may be more prevalent in adolescent age individuals. You probably heard about with narcolepsy individuals displaying automatic type behaviors. And those are basically just kind of semi-purposeful movements without recollection or awareness. It can be quite involved. Some people, will type. There's reports of people driving doing those kind of automatic behaviors, and they'll, say things like, I drove to X location and don't have a recall of having done that. And that can be in up to about 8-10% of patients with narcolepsy. And it can be seconds to minutes, so it can be prolonged. And definitely you want to have your guard up for that, because obviously you can imagine the situations that you get into there. But also with these automatic behaviors, further compounding it, a lot of people will experience eye or vision changes, sometimes double vision, blurred vision, drooping of the eyelids, those kind of things. Okay. So in addition to the type 1 and type 2, you also have familial forms of narcolepsy, and then what we call symptomatic narcolepsy. We've kind of gotten away from those labels, but I think it's useful to illustrate some points. The narcolepsy with cataplexy, okay? In terms of diagnosis, obviously you have the cataplexy, the excessive sleepiness for at least a period of 3 months. And this is just kind of a by definition in terms of being able to label the diagnosis. And that hypersomnia is not explained obviously by another condition. So if you started working third shift 3 months ago, and now in recent months you have excessive sleepiness, it's probably not narcolepsy. It's probably that you're working third shift. Anyway, definitely you want to prove that. Okay, so you want to do the polysomnography, including multiple sleep latency testing the next day. Or with these individuals, another acceptable option is to order a lumbar puncture and send that for a hypocretin level, a hypocretin 1 or orexin level. And that is commercially available now. Those tests can be sent to the Mayo Clinic in Rochester, and there is a test available. So for some reason somebody can't do the multiple sleep latency test, you actually can order that lab on the spinal fluid. With narcolepsy without diagnosis, it also includes the excessive sleepiness, at least a 3 months duration, not explained by anything else, but really you're kind of limited to the traditional polysomnography followed by multiple sleep latency testing. The familial forms of narcolepsy that we talked about, several of these actually can have low or undetectable hypocretin levels, as many as 2 and 5. They seem to be less likely slightly to have the classic HLA marker that's seen with narcolepsy, the DQB10602. It's sort of a heterogeneous group, okay? And very few of these individuals of narcolepsy patients have first degree relatives. So you're not talking about huge numbers here. Right. There's also symptomatic or secondary narcolepsy. And this is most often seen in instances where someone's had damage to the hypothalamus, okay? Because that's where the hypocretin is synthesized. So it creates a hypocretin deficiency. You have also hypothalamus and pituitary axis pathology that can sometimes create an issue. Pituitary tumors can grow and interrupt transmission of the signals from those hypocretin neurons. Sarcoidosis, an inflammatory condition, can affect the hypothalamus. Sarcoid can affect almost any part of the entire body. Arteriovenous malformations in this area. And then one of the more common tumors that you see in the hypothalamus called craniopharyngioma can also induce a narcolepsy type picture. Head injury, radiation treatments directed to this area can induce it, and also hypoxic ischemic injuries. And in these individuals, you do see those low hypocretin levels as well, obviously, because it's something interfering with that hypocretin synthesis. So in terms of pediatric narcolepsy, 34% of narcoleptic patients have their symptom onset before age 15. So I know, I was saying earlier, the most common presentation is, kind of adolescence, young adulthood, but in as many as a third, it can be before age 15. And in much smaller percentages, even before age 10 or 5, even though I can't imagine making the diagnosis myself in somebody less than 5, that'd be pretty tough to do. But it has been reported. They usually nap longer whenever they do nap than even in adult patients with narcolepsy, as long as a half hour to an hour and a half. And again, this is kind of, fairly routine napping. I know you may say, well, gosh, on the weekends, I can take a nap for 90 minutes, but this is something that's pretty common. And in kids, this is interesting too. I think I've never seen this, but cataplexy can present differently. So it can present as these tongue thrusts, or as another dyskinesia. So a dyskinesia is an abnormal extra movement. So that's pretty interesting that cataplexy triggered by emotion can present as dyskinesias in children. Mood swings are common in pediatric narcoleptic patients. And a lot of times it's confused with ADD, much like sleep apnea is. So there are quite a few things that get labeled ADD that may not necessarily be. So what causes it? With type 1, we know it is a hypocretin deficiency, okay? Thus manifesting with the cataplexy early on. In type 2, that pathogenesis is much less clear, so that's not been fully delineated yet. So obviously with the normal hypocretin levels in so many of these individuals, you certainly can't rely on that, and it doesn't appear to be the causative issue at hand. There's nothing in particular to suggest an inflammatory role, so there's no inflammatory type markers that appears to be at hand. You can get REM atonia during wakefulness, okay? And that's because of these, and I'll show you this in a slide here in just a second, but you get this flip-flop between sleep to wake, okay? So the hypocretin system is a stabilizer of our wake state versus our sleep state. And so when you remove that stabilizer, so it's easy to flip from one to the other, okay? And I'll show you in a second. And then I'll put everybody to sleep because it shows some neuroanatomy. But on the flip side of that, you can get this REM dreaming intrusion into wakefulness, and that's how it manifests as the hallucinations, okay? So the REM atonia during wakefulness, that's what you're seeing as, cataplexy and sleep paralysis. So let's see. So that's just what I was saying a second ago about how the hypocretin system stabilizes, basically. Can you see if I move? No, you can't see. Okay. All right. I'm going to have to bear with me for 2 seconds. I won't bore you too long with this, but it is interesting. So what you get with the hypocretin system, okay, you can see these circles up top. This is on the left-hand side when you're awake. Over on the right-hand side, it's when you're asleep. So during wakefulness, your hypocretin system is active. So that stimulates brainstem nuclei, the locus coeruleus, tuberomammillary nucleus, and the raphe nucleus, all of which, when they are active, promote wakefulness, okay? So then when they're active, they inhibit the ventrolateral preoptic nucleus involved as your sleep generator, okay? So it's off. When it's off, it's no longer inhibiting your hypocretin system. So you can see how, in this cascade, how much the hypocretin system being active promotes wakefulness, okay? Well, now if you move over to the right-hand side, this is in sleep, okay? So in sleep, your ventrolateral preoptic nucleus, that is active, so therefore it is inhibiting your hypocretin system, which then is no longer stimulating these wake neuron centers, which then no longer inhibits the VLPO, but the VLPO is inhibiting that, so that results in sleep. Okay, so on both of these sides, if you cut the top half of those triangles off, then you've got this flip-flop switch. You've removed your stabilizer, okay? Think of the hypocretin system basically as your conductor, deciding which train tracks you're on. Does that make sense? Okay. Thanks for indulging my neurology history there. So with hypocretin 1, you get your maximum activity and release during wakefulness. In narcolepsy with cataplexy, the levels are less than or equal to 110 picograms per milliliter, or 1/3 less than your control values, okay? Normal is to have greater than 200. Okay, so you can see you have quite a deficiency in order to see that. And we'll skip the bottom part. It's just kind of more of the neuroanatomy side of that. If you're interested, we can look at them later. The HLA typing, the DQB10602 positivity on chromosome 4, you see that in 85 to 93% of patients with cataplexy. Without cataplexy, it can be present in up to about a third to a half. But you can't just base it off of that. So if you have HLA DQB10602, you see that in up to 20 to 22% of just your normal control Caucasian population, and in a third of African-American control population. I couldn't find numbers in other control populations, but anyway, regardless, that's very illustrative of the fact that it's fairly common. So again, contributing to that kind of multi-hit hypothesis. It's not just this. It's not just some benign sort of infection that you had that triggers the autoimmune process. You probably have to have the susceptibility plus something triggering an autoimmune process, for example. Right. Narcolepsy is associated with a number of other conditions, including sleep apnea. So in other words, you see more sleep apnea in individuals with narcolepsy as opposed to without. You see more sleep terrors, sleepwalking, periodic limb movements, and REM sleep behavior disorder. So if people are complaining of a number of different things, you know, it doesn't mean that they don't have several conditions. They certainly can. Some of the other things that you have to think about with narcolepsy is untreated sleep apnea, obviously a very common cause of excessive sleepiness, idiopathic hypersomnia, some of the periodic hypersomnias that we'll talk about, circadian rhythm disorders such as the shift work, but also advanced or delayed sleep phase. You know, a lot of people think a teenager has narcolepsy when really it's just that they would rather go to bed at 3 a.m. and get up at 12 noon, you know, or worse. So a heck of a lot. And then, of course, insufficient sleep, like we mentioned, and anything really that disturbs sleep. Everybody, you know, kind of knows this from what we've talked about. So there are a number of different polysomnogram findings in narcolepsy, a decreased latency, early onset REM periods. And in fact, you can even use an early onset REM period on your PSG in conjunction with a REM period during your MSLT to make the diagnosis. So you can have some of your SOREM or one of your SOREMs during that nighttime sleep study the night before. Yeah, so like in order to, you don't have to have two. You can have one sleep onset REM period during your MSLT. And if they went into sleep in the first, REM sleep in the first 20 minutes of their PSG that night before, then that qualifies as two SOREMs. So yeah. They have typically a fragmented sleep architecture. So a lot of times, and that's because of that flip-flop switch issue. So just like they can have interrupted wakefulness with sleep, they can have interrupted sleep with wakefulness. So they tend to have increased awakenings, arousals. You can actually get a decreased total sleep time overall, less slow wave sleep, increased movements. And interestingly, with type 1 or with cataplexy, narcolepsy, they tend to have even more arousals and a poorer sleep efficiency versus type 2 or idiopathic hypersomnia patients. So speaking of idiopathic hypersomnia, tough thing sometimes to diagnose, usually tougher even to treat because most carriers of insurance won't recognize it as a true entity. So you have a real tough time getting medications approved. But this is where you have this pervasive excessive daytime sleepiness And your differentiating cutoff for whether it's with long sleep time or without long sleep time is the 10-hour mark. So if they typically sleep longer than 10 hours, then that's idiopathic hypersomnia with long sleep time. Okay. And oftentimes actigraphy can be very helpful at diagnosing that. With these individuals, they typically take prolonged daytime naps, and typically they're not refreshing. That's a key hallmark of they can take a long nap of an hour and they wake up and they still feel that sort of excessive sleepiness, that sleep drunkenness, if you will. Usually comes on in early adulthood. There can be a family history. We don't know what causes it. There's no particular associations with genetic markers, and they typically have more typically have normal hypocretin levels. And it can be tough to treat. It really can. There's really no specific pathognomonic feature that when you hear that, it's like, oh, that's got to be idiopathic hypersomnia. They can be very difficult to awaken. So anytime you hear somebody where they say, literally I had their shoulders, shaking them, and they still were not coming around and waking up fully. That's that sort of sleep drunkenness or sleep inertia, where even after prolonged sleep, they're not refreshed. They can be kind of confused and out of it. They can have automatic behaviors like we talked about earlier, and even micro sleeps, during the daytime. Okay. And everybody knows about micro sleeps, right? Where you can even be talking with somebody, but you can actually get, drop out of your full alert alpha rhythm. And then, and those individuals who are doing that, and then, the most common cause of that's not enough sleep, and you're going into micro sleeps. And we've all probably done that, where you just realize, oh, I just zoned out. Yeah. And and they can't even do it with their eyes open. And then, and so sometimes I think these individuals, later will say, you didn't tell me that. And you're like, no, we were standing here talking yesterday and I said it, that kind of thing. And it makes sense, right? If you drop out your rhythms, then you're not going to retain, are you? There tends to be an association with psychiatric illness with these individuals. You can see an increased sleep efficiency and increased stage N3 sleep, and less drowsiness or stage N1. And by definition, they have fewer than 2 sleep onset REM periods if you do a multiple sleep latency test. All right. So how many have ever heard of Klein-Levin syndrome? Yeah, a few. It's very, very rare. In a career, you may never see it, or very few cases. But it is a recurrent hypersomnia, so it's episodic, okay? And the key hallmark with these individuals is if you measure their 24-hour melatonin, they have increased levels of melatonin, okay? And during the episodes, they can have profound sleepiness, up to 18 hours a day, okay? And it occurs usually in 1 to 2 week periods. That can be variable. It can be as few as just a few days, up to as much as a month or slightly more. And it has to occur at least once every 18 months. So it can be variable. But by definition, it has to be at least every 18 months or 1.5 years in order to label it as Klein-Levin. The classic descriptions of symptoms coming along with the excessive sleepiness is a hyperphagia or increased eating, okay? And they can hoard food. So sometimes you'll find food underneath the pillow or things like that, but it's only during these episodes. They don't otherwise. And hypersexuality during the episodes as well. But that's only in about 50% of cases that you see those two things, but that's kind of the classic description of it. So in order to make the diagnosis, it has to be the excessive daytime sleepiness plus altered perception, okay? Cognitive dysfunction, and that can vary in terms of how it presents. abnormal eating pattern, or disinhibition. And in my experience, kind of the easiest thing to pick up on in the history is kind of the disinhibition. So and that's where kind of things like the hypersexuality plays back in. Sometimes it can just be, relatively subtle things, but it can be things that the parents would say, this is not them. They don't do that otherwise. They don't act this way or, say things like this outside of these episodes when they stay so sleepy that we can't keep them awake. We don't know exactly what's at play with this. Is it autoimmune? Can you see it sometimes with hypothalamic or paramedian thalamus, some of the deep brainstem nuclei lesions? That's possible. Most commonly, it's in adolescent age males. You can see impaired recent memory during their episodes. In a minority of patients, but still in the higher than what you'd expect, there can be a preceding viral infection. So that certainly begs the question about, is it autoimmune? There's a possible Hla association. So again, it's another one of those things where, gee, everything's pointing to kind of this multi-hit hypothesis that you've got a predisposing factor genetically, but it probably takes more than just having that predisposition. They can gain substantial weight during the episode, even though it's days to weeks. They can actually put on quite a bit of weight from their hoarding type behavior and hyperorality. Usually it goes away on its own, okay? But it can be for quite some time, up to a decade and a half, something like that. If you do the sleep study during their episodes, they have high sleep efficiency, decreased slow wave sleep, and increased drowsiness or N1 sleep. On the multiple sleep latency test, by definition, they have less than 2 sleep onset REM periods, and typically a mean latency of between 5 to 10 minutes. Stimulants, interestingly, don't tend to be of great benefit for these individuals. You can try it, and people do certainly, but other medications have been used. Lithium to prevent the episodes, carbamazepine and topiramate has also been used. There's another thing that you should definitely always ask about if somebody has these recurrent episodic excessive sleepiness situations in females. And there is a phenomenon known as menstrual associated hypersomnia. And just like the name would suggest, it's associated with menses. We don't know a whole lot about this. Is it a Klein-Levin variant? Possibly. Topiramate has been used for treatment. It's kind of hard to get enough numbers on this to have hard data for saying, what's truly effective, what's really not. But that's definitely something that you'd want to inquire about and ask about if someone brings, especially an adolescent age or young adult age female to your attention in the office. So, and another thing, I always like to throw in the rare bird things just for fun, just to make sure everybody's heard about them at least. You may never see it, but there's another interesting phenomenon known as idiopathic recurring stupor, or an endazepine stupor. And that's recurrent episodes of just what it says, a stupor. Usually this comes on in adulthood. It can last hours to days, and it's quite variable in terms of how often it happens. It can be up to weekly or just a few times per year. And on EEG, if you're doing that during these episodes, they get this kind of non-reactive fast activity, 13 to 18 hertz activity. And interestingly, flumazenil will reverse it. So very interesting. So if somebody comes to you, complaining of recurrent episodes of a stupor, I'm still waiting for my first person to present with that, but it's out there and in the literature. Then you can use that to try and see if that makes a difference. Just briefly, we'll look at pharmacologic treatment. For excessive daytime sleepiness, we'll talk kind of about some of the other unusual conditions and some of the atypical medications that you might not think of, like lithium and topiramate and so forth. But we're talking more in terms of your garden variety, narcolepsy, excessive sleepiness conditions. And really kind of you're looking at, your methylphenidate class, the amphetamine classes, and then more recent non-traditional type stimulants. The methylphenidate, the Ritalin, you can have Ritalin, Concerta, kind of the long-acting forms of that. You shoot for a target, you shoot for less than a ceiling dose of 60 milligrams per day. They can be quite effective, but they do, of course, have potential side effects, including anxiety, irritability, feeling a motor restlessness during the day. Headaches are fairly common, definitely can affect appetite. Okay. So you have to make sure, if someone's taking that, they're not, getting malnourished basically from not eating and dropping weight precipitously. Anything that is a stimulant can cause insomnia, potentially rash. Whenever you start on any of these kind of medications, really, you want to make sure you're checking blood pressure and pulse rate to make sure those are not affected, because that's variable from individual to individual. And even in people who don't have a history of psychosis, sometimes these stimulant medications can induce that. So just be aware. So if there's something really new, then it can be the medication doing that. We'll come back to that. All right. The amphetamine medications, these are your Adderall type medications. Those work by facilitating dopamine release and blocking reuptake. And again, much like the other, the methylphenidate class, you have immediate release and extended release formulations. All these can be very, very effective. And again, similar kind of side effects, okay? Of the more newer generation or non-traditional stimulants, probably the most commonly used is modafinil or armodafinil. Armodafinil just being the more active enantiomer form of modafinil. And that reduces dopamine reuptake. But it also appears to possibly have some action on the hypocretin and glutamatergic systems, so other neurological systems with neurotransmitters. Modafinil, dosing can be anywhere from 100 to 400 milligrams, usually is BID dosing. Some people can get by with just single day dosing. Armodafinil, anywhere from 75 milligrams to 250 can be effective. Potential side effects, you have to definitely be on the guard for a potential rash, headaches, nasal stuffiness. Things like headaches or nasal stuffiness oftentimes will extinguish after about a week or so of treatment. So if it's just relatively mild, I always tell people kind of hang in there for a week and see if that goes away. Not something like a rash. Obviously, if it's a rash, you stop it, because it can be severe, the severe Stevens-Johnson type rash and syndrome. Can make people feel kind of anxious or nervous or jittery with that kind of tremor. Very rarely, they can trigger angioedema. Angioedema appears like the neck swelling and tongue getting thick. Of course, which you have to be super careful about, because obviously that's where you'd want to get somebody to the emergency room if they have that. Again, psychosis, hallucinations, suicidal ideation. And one important thing to know with this and some of the other non-traditional stimulants, it can reduce oral contraceptive pill effectiveness. So you definitely don't want to be blamed for an unexpected baby. So you always have to tell people, this is important. If you take this, don't rely on oral contraceptive pills doing the job that they normally would otherwise hopefully do. But modafinil and armodafinil tend to have less sympathomimetic toxicity. In other words, usually fewer effects on things like blood pressure and pulse rate, things like that. There's pitolisant, which has been effective in has been available in Europe for a while, but more recently, in just the past couple of years in the United States. And it's got a novel mechanism of action. It increases central nervous system histaminergic transmission. So, when people hear the word histamine, they think of sleepiness, but you got to remember those are antihistamines. So this is the opposite. This is histaminergic stimulation, okay? So the net result of this is it promotes wakefulness. Interestingly, this can be effective for hypersomnia and cataplexy, okay? So definitely if you have a type 1 narcolepsy patient, this is a good consideration to think about this. Definitely not approved. Maybe if you could talk somebody into trying it and you could afford it, because I'm sure it's probably quite pricey. And that just kind of goes through some of the dosing of it. All right, but possible side effects you have to be aware of, of course, insomnia, nausea, anxiety, and it can affect on an EKG, your QT prolongation. So if somebody has a prolonged QT, then you definitely wouldn't want to use this. This also can interfere potentially with oral contraceptive pills. And in general, you try and avoid this with liver disease, possibly with renal disease as well. Solriamfetol or Sunosi is a dopamine and norepinephrine reuptake inhibitor. And you can use that for treatment of narcolepsy as well as hypersomnia related to obstructive sleep apnea. It's been approved for that as well. In my experience, it's a very good medication, works quite well. In my experience, I think it has fewer of the sympathomimetic effects as compared to even our modafinil or modafinil. It seems to be a really clean medication and very effective. So I like it. Hopefully more insurance providers will affect its tier status over the years and make it more readily available to patients. You can have a little bit of a tough time getting it approved, but very effective. Again, but with any of these stimulants, it can increase heart rate, blood pressure, potentially lead to insomnia, similar kind of, effects with anxiety, psychiatric effects, appetite suppression, all those kind of things. Specifically for, and we'll close with these, but the cataplexy agents, in addition to the Wakix or pitolisant, then sometimes that can be really tough to control. The cataplexy can, and people don't like that. Obviously, I've had people come in who said, I've just kind of trained myself to not laugh, even if I think something's funny. So you don't want that. You want people to be able to laugh and experience normal emotions. But some of the cataplexy agents can affect serotonin and norepinephrine reuptake. The antidepressants are usually the medications that you use first, especially the serotonin and norepinephrine reuptake inhibitors like venlafaxine, for example. And in my experience, it can be quite effective. It really can, just the SNRI, venlafaxine. But again, there's pitolisant and then sodium oxybate as well, or Xyrem or Xywav, okay? This medication has a profound effect on increasing slow wave sleep, okay? And that can lead to, potentially some of its side effects like the enuresis and so forth, because you're really, really pushing that slow wave sleep drive. You do have to be very careful with it though, because it is a derivative of gamma hydroxybutyrate or GHB. Okay. So it's only produced by one pharmacy, period. And all of it comes from them. And you definitely want to stress the importance of making sure it stays locked up at all times. Even though you may trust everybody in the house, it just needs to stay locked up. But it can be very, very effective for cataplexy, reducing cataplexy by as much as 70%. In divided doses, it may sound odd to take a narcolepsy patient and gives them something at the time that they go to bed, and then also 4 hours later in the middle of the night. But you set an alarm and they take that. And that's how effective it is too, for putting people back to sleep. Even though you're setting an alarm and they're waking up in the middle of the night, they take their second dose and they go back to sleep. But it can be at the higher doses, it can be very, very effective for excessive daytime sleepiness as well. Okay. You don't want to use it if someone has COPD or obesity hypoventilation. And you don't want to use it in combination with other central nervous system depressants because of that incredible degree of effectiveness. I threw in some slides here about, just assessment, but everybody knows about this with the multiple sleep latency test. Just one slide I want to show here. There are many medications which can affect that. So obviously, if you're doing an MSLT for narcolepsy, you want to be able to see that REM onset. And many medications really need to be taken off for quite some time prior to at least 2 weeks prior to having an MSLT. Otherwise, it's uninterpretable, because if you're on a REM suppressant, with the most common really being like the SSRIs, the serotonin specific reuptake inhibitor antidepressants, that really can dramatically throw off your results. But you can see, other medications, beta blockers, ideally, and it's not to say that you can't do it with people on these, because let's face it, there are a lot of people on things like beta blockers and things like that. But, obviously there's some that you want them to be off of, like your stimulant medications and things like that, or you're totally going to mask results. But all of these can suppress those REM findings. Yes, yeah, like metoprolol so a lot of people with high blood pressure will be on metoprolol, or some people with just like a sinus tachycardia will be on metoprolol to control heart rate. So ideally, if they can, but to be quite honest though, more commonly, if they're on something like metoprolol, I tend to continue it and still do the MSLT. We're talking about an ideal, perfect world, which of course none of us live in. I'm just saying you have to take that into consideration. So if somebody says, every time somebody tells a really funny joke, I laugh at it really hard and I can't hold my head up, and I'm sleepy all day, every day, and they have one SOREMP on their MSLT and they're on a beta blocker, you just take all that into consideration. So it's still probably narcolepsy. Of course, in that circumstance though, you could do a spinal tap if you could talk them into it, and and send that hypocretin level and check that. So, all right. So, and then of course, there's just other things like maintenance of wakefulness test. Sorry for going over a little bit. I know we had a little bit of a delay there from the technical side getting started, but anyway. And yes, ma'am. Mm-hmm. Yeah.
But she is on 60 milligrams of she is on Alexa for the cataplexy. They tried taking her off the Alexa and put her on something else, and she started having
Oh.
Is that common for somebody to be on that?
It can be. Yeah, it certainly can be. So in that circumstance, there are different things you could consider. One, perhaps something like the venlafaxine instead of the citalopram or Celexa, just because you're picking up that norepinephrine side too, with citalopram being the serotonin specific reuptake inhibitor. You also get serotonin and norepinephrine reuptake inhibition with medication like venlafaxine. So that's something to consider. And then somebody like that, I would consider trying the Wakix or pitolisant, because that can be quite effective. Maybe because then, maybe, who knows, maybe she could try that and that could replace her. Right. Sounds like, yeah, in terms of what's recommended.
Mm-hmm.
Yeah. A lot of times those people have to have those kind of divided doses. Yeah, so yeah, I would say that that's a good consideration to look at a medication like that, because potentially she could have that replace a couple of her other medications. It's not extremely high. I mean, it's on that, upper end, but it's not inordinate, to hear that. That's not unusual. They used to. Yeah, a lot of people don't. A lot of people tolerate relatively high doses of that. And years ago, it's kind of interesting because people would use even higher doses of the stimulants. That used to be more common. So yeah. That may have been like the sodium oxybate. Yeah, that may very well have been that, because that can be quite effective. Yeah, that had to have been that. Yeah, sure. And that can be effective. If it were me, I would probably try the pitolisant before I went to that. Not to knock that, it's extremely effective. It's just, obviously it's less complicated. Oh, yeah. Yeah, absolutely. Yeah. But no, and it may just be that, when a lot of her medications were tried, it was before that came out, the pitolisant, so they may not have tried it yet. And, when they've gotten her on something that's working at least relatively well, they've tried to, not rock the boat, so to speak, and kept her stable on that. But that's definitely something to consider. Well, thank you all so much. I'll be around if you have other questions. Oh, yes, ma'am. After a traumatic injury inducing a narcolepsy. Is that what? Yeah. It depends. I mean, obviously, usually it's close thereafter. You don't tend to get a delay, so you don't tend to get like a traumatic brain injury and then, a year later develop the narcolepsy, because it tends to be related to the pathology that caused that. Well, I mean, usually it's afterward. Yeah, after the event. I mean, there's always, it depends, because it depends on the nature of what kind of injury they experienced, because you can get, that recovery period. So the initial shock to the system, and then, of course, that can be days to weeks. So you can't really assess it in that time frame, and you have to kind of wait and see where things kind of level out, basically, after that, from the effects. But again, that's the kind of thing too, though, that can improve after a while, just because with neurological healing, that's it's much like with stroke. You don't always get all of your improvements right away. People can still improve from that as much as a year, potentially a couple of years after. All right. Well, thank you very much.